Chapter 20 covers non-opioid analgesics, non-steroidal anti-inflammatories or NSAIDs, and anti-gout drugs. So again, another long chapter. I'm going to try to fit it all into one lecture here instead of going on to a second video. So inflammation. The inflammatory process is a normal response to injury, and it's considered the first step of healing. Inflammation can become exaggerated, which leads to further tissue damage, which is why we might want to give someone an anti-inflammatory. When tissues are damaged, substances such as histamine, bradykinin, prostaglandins, and serotonin are released that produce vasodilation and increased permeability of the capillary walls. So that capillary wall, as it has increased permeability, allows substances to leak out, which causes swelling. As blood flow to the damaged area increases, leukocytes or white blood cells migrate to the area to destroy harmful substances produced by the injury. The effect leads to the cardinal signs of inflammation: redness, swelling, warmth, pain, and loss of function. So inflammation is a good thing, but it's also a bad thing if it stays around for too long. So on slide 5, a little picture of exactly what inflammation looks like. And moving on, anti-inflammatory drug action. Steroidal anti-inflammatory substances, steroids, such as cortisol, hydrocortisone, and prednisone, inhibit the formation of arachidonic acid, whereas NSAIDs, non-steroidals, selectively inhibit the cyclooxygenase enzymes. Both of those big long terms I just mentioned are involved in the inflammatory pathway. So if we inhibit them, we inhibit inflammation. So cyclooxygenase enzymes are abbreviated COX, and there are different types, COX-1 and COX-2. COX-1 is believed to be in all cells, especially in the platelets, kidneys, gastrointestinal tract, etc. COX-2, on the other hand, appears to be manufactured in activated macrophages in response to injury or damage to local tissues. So NSAIDs ease the symptoms associated with inflammation because they inhibit prostaglandin synthesis in many different tissues in the inflammation pathway. So non-opioids differ from opioids in the following ways. They're not chemically related to morphine. They're not effective against sharp pain. They produce analgesia through CNS and peripheral mechanisms of action, and they do not produce tolerance or dependence. Most of these are all good things. So, NSAIDs are related, they're not structure related to cortisone or steroids, that's why they're called non-steroidal. However, they have a little bit of a different mechanism of action. It's still the same effect. So, non-opioids, there are 3 groups within this class distinguished by their pharmacologic action: salicylates, traditional NSAIDs, and COX-2 selective inhibitors. So covering salicylates, aspirin and salicylic acid are the main salicylates. They're the oldest and most frequently used non-opioid analgesics. They have analgesic or pain, anti-pain, antipyretic or anti-fever, and anti-inflammatory action. So again, that's analgesic, antipyretic, and anti-inflammatory for the salicylates. They were discovered a very long time ago as a product of willow tree bark. Native Americans drank tea and beverages made from willow tree bark to relieve headaches and toothaches. So salicylates that you see today that are used include aspirin, and methyl salicylate, which is oil of wintergreen, usually a topical only for that last one. So they affect the hypothalamic centers in the brain. Aspirin is a potent inhibitor of prostaglandin synthesis, which decreases inflammation. Salicylates block COX-1, so all of the COX-1 is believed to be in all cells again, remember that, so this is important for the side effects of aspirin. So they're very good at reducing inflammation. However, they do come along with a couple problems. They can, because prostaglandins are involved in stomach protection, if we prevent prostaglandins, our stomach protective layer is broken down and gastric ulcers can result. Okay? So aspirin helps reduce the risk of reinfarction after a myocardial infarction. It can lower the risk of heart attack, and it's, again, good for inflammation. Chronic salicylate intoxication, which means too much of a good thing, can cause nausea, vomiting, and salicylism, which is a series of symptoms that includes ringing in the ears, headache, delirium, and hyperventilation. Aspirin should not be given to children with chickenpox or flu-like symptoms because it can result in Ray's syndrome. In addition, we just generally don't give aspirin to children anyway. It's usually used in adults only. It's used for mild to moderate pain, osteoarthritis, and rheumatoid arthritis. It does say it's safe for use in adults and children. Again, we typically use Tylenol or ibuprofen in children. It's available in a variety of formulations: capsules, tablets, solutions, gums, etc., chewables, a bunch of different options out there. On slide 13, it gives you a list of recommended adult doses of NSAIDs. Again, don't memorize doses, it's not important, you can always look that up. And they kind of stuck that in before we got to any of the other ones, so don't worry about that slide too much. Okay, it's a long one. Moving on. Acetaminophen is effective in treating headaches, fever, and minor musculoskeletal pain. So in this case, it is not an anti-inflammatory. It is strictly analgesic and antipyretic. Good for fever, good for pain. So acetaminophen is effective against the pain of headache because it inhibits prostaglandin synthetase within the CNS, but it is not the drug of choice in treatment of pain associated with muscle aches and inflammation, because remember, it doesn't work on inflammation. So usually we'd use it for fever, minor aches from the cold and flu, headache, etc. So we don't have to worry, whereas with aspirin, we worry about aspirin having an effect on our platelets and thinning out our blood. We don't have to worry about that with acetaminophen, and we also don't have to worry about the GI disease because it doesn't have the same effect on the stomach. So, not have inflammatory properties. Acetaminophen is available again in a variety of formulations: suppository, solution, tablets, capsules. It is available without a prescription. However, there is a limit, 4 grams per day in adults, that we kind of try to remind our patients about. Anything higher than that can cause liver damage. And so, treatment of overdose, because people do often accidentally overdose and some people purposefully overdose. If you catch it in time before it's been absorbed, you can use gastric aspiration and lavage or activated charcoal to have the patient throw up the medication. However, an antidote for acetaminophen poisoning is N-acetylcysteine, or acetadote. Can be given orally or parenterally. So the reason we are so nervous about this is because acetaminophen is in a ton of over-the-counter products: cough and cold, Tylenol, there's a ton of different products out there that contain acetaminophen. So a patient can be taking it and not even realizing that they're overdosing on it because they're not aware it's in their medication. Moving on to NSAIDs. So all NSAIDs interact with cyclooxygenases. Our NSAIDs include ketoprofen, indomethacin, ibuprofen, naproxen. There's quite a few out there. So the newer generation of NSAIDs, celecoxib, is selective for COX-2 only, and it's in those macrophages that cause inflammation. So this is important because it's not going to have the same side effects as our older NSAIDs. Pain relief for the Celebrex or the COX-2 inhibitor is not better. It just comes along with fewer side effects like ulcers and gastric bleeding. NSAIDs are available primarily for oral administration, and they are both OTC and prescription only. So we have ibuprofen and naproxen, which are OTC. However, indomethacin, ketorolac, nabumetone are all prescription only NSAIDs. So, all anti-inflammatory drugs may produce nausea, gastrointestinal distress, ulceration, vertigo, vomiting, mental confusion, and headaches. Overdose of NSAIDs is similar to salicylate overdose, and there is no specific antidote for NSAID poisoning. NSAID use is discouraged in elderly patients. It does have a negative effect on our kidney function, and as we remember, our elderly patients already have decreased kidney function as it is. So every OTC product with an NSAID should include a warning for severe stomach bleeding in people who are 60 years or older, have a history of stomach ulcers or bleeding problems, take a blood thinning or steroid drug, take other drugs containing NSAIDs, or drink heavily. We want to make sure we are watching out for this because once that bleeding starts, sometimes it can be hard to get under control. Moving on to gout. Gout is an inflammatory disease caused by uric acid crystal formation in the joints and soft tissue. So some foods with high purine content precipitate gouty attacks because they build up that uric acid. Inflammation of the joint is caused by the phagocytes trying to remove the uric acid deposits. So it's kind of a vicious cycle. Those phagocytes come in and attack the uric acid crystals. This leads to a decrease in pH, causing more uric acid to accumulate in the joint and thus more swelling. Most commonly seen in the big toe and some of the other smaller joints of the hands, and it can be very painful. Drugs that are useful in the treatment of gout are either used to relieve inflammation or to reduce uric acid levels. So first, colchicine alters the phagocyte's ability to attack the uric acid crystals, thus halting that cycle. It is not an analgesic, and it's not a general anti-inflammatory drug, so it's only used in gout, and it's only used to prevent the phagocytes from attacking the uric acid crystals. Two major classes of drugs that are used in the long-term prophylaxis or prevention of gout include hypouricemic agents, exactly what they sound like, bringing that uric acid level down, and uricosuric agents. So our hypouricemic agents, allopurinol and febuxostat. Allopurinol inhibits the enzyme xanthine oxidase, which is necessary to turn hypoxanthine into uric acid. Most common side effects associated with the use of allopurinol are fever, rash, and leukopenia. Uricosuric agents, probenecid. Well, actually, let's talk about febuxostat real quick. It's the first selective xanthine oxidase inhibitor that is not a purine analog. It is used for the chronic management of hyperuricemia in patients with gout. It's more potent, which is why it's similar but a little bit better. So probenecid enhances the renal excretion of uric acid without altering the formation of it, so it leads to a rapid clearance of uric acid from the blood. Slide 23 covers the drugs that we just talked about. Anti-inflammatory drugs are used in the treatment of gout, such as naproxen, ibuprofen, to help with the pain from the swelling and to bring the swelling down. And last but not least, drug interactions for these medications. Anti-inflammatory drugs and non-opioid analgesics undergo a variety of drug interactions. So always be aware of that. There are a lot of interactions for these medications, especially if someone is on a medication that can affect their kidneys or cause increased ulcer formation. So you always want to be on the lookout for that. That covers chapter 20, and have a great week, guys.